I better like, put on my jacket and tie and say formal welcome to everybody. Happy New Year. Thanks as ever to everybody for being so wonderful. I've had so many lovely replies to just sort of sending out the little note. And look, we've got an absolute dream today because we have a wonderful friend and colleague, Maureen and Nana, going to talk to us about listening and listening as a way to kindness. And what's lovely about this, Maureen, and you know this, and I think in the work, and you'll reference all sorts of other people's work, but we've had all sorts of people get in touch. I had an amazing conversation with somebody who knows Nancy Klein very well, and her wonderful book Time to Think, Listening with Fascination. Michael West has done lots, and Bridget, it was just lovely to hear from you and Charlie about your fantastic spaces for listening, and give you a little shout out in the work. And I'm sure you'll contribute to this conversation in the chat, and we should go and revisit that as well. But Maureen, without further ado, it's so lovely to have you with us. And I know you've had a week of already been doing all sorts of epic things in the spirit of kindness, haven't you?
Yes, that's my my everyday. Try and do something that will, I think, make the world a better place. That's my job, my life, my mission.
You do it so well. Right, listen, I'm going to go on mute. Over to you, and you can shout next slide at me, and I will find the next slide.
Okay. So Nana should be joining us shortly, but Nana and I have been working on this idea of listening as a way to kindness. And so if you go to the next slide, I'll just start with a quick story that many of you may have heard of from Belgium, where the woman on the left, Anne, is a journalist with the public radio station, public broadcasting station, was making a video about healthcare. And she kept meeting up with Vivienne, who had been in the intensive care unit and intubated for a few weeks and now was extubated. And so when the journalist went in, she asked her a question. She said, "Is there anything that you're looking forward to?" She had been making this video, but at the end came back to this question. She said, "Is there anything you're looking forward to?" And Vivienne paused for a moment, and then she said, "You know, I'm really looking forward to a mango." So if you go to the next one, the journalist went out to the store and brought her a mango and also a mango smoothie because she really was just restarting eating again. And the staff asked themselves the question, why did we never stop and listen to what somebody's looking forward to? And so that, as you may know, turned into mango moments. And now this idea of mango moments has spread around the world. And it basically is a tribute to people just stopping and listening. The next slide, Len's on the call here. Len, and you might want to say a word about the role of kindness in cancer care. Len's been doing a lot of research, senior fellow for IHI, and the 6 types of kindness were identified. Number 1, deep listening. Len, do you want to add?
Go ahead, Maureen, please. You're doing great.
And so what Len is saying here is really giving us, I think, some very specific things. And that's what Nana and I are going to talk about today, are very specific tools that we can use to improve listening. But when I saw Len's work, it really struck me that number 1, when we're thinking about kindness in cancer care, such a stressful moment in people's lives, that number 1 was deep listening. If you go on, then many of you have heard me talk about moving from only asking what's the matter to also, next slide, what matters to you. And from around the world, we're finding incredible stories of impact for patients, for families, and for staff when we ask that simple question. And so next one is just a map of the movement is spreading around the world. If you want to join that one, the website there is up in the upper right-hand side, wmty.world. And we, like the kindness folks, meet monthly and are doing research into the clinical impact, the emotional impact of asking the simple question and then acting on it. And so, Nana, I'll turn it over to you now. And Nana's going to describe the listening arc, 5 important ways for us to think about listening as an act of kindness. Nana?
Thanks, Maureen. Good morning, good afternoon, good evening, everyone. It's a pleasure to join you here today. So this leadership listening arc came about after I was invited to speak with a group of people who were working on joy in work with an IHI collaborative a couple of years ago. And as I thought through what are the most important things that we can do from a leadership perspective to show that we are listening, that we are doing something, I started kind of conceptualizing these elements, these 5 elements, and have developed them further and eventually published them in the Healthcare Executive last year. So I would like to spend a few minutes going through each of these. Next slide, please. Starts with curiosity. I learned this very early on from Don Berwick, IHI, who was very clear in how important curiosity is in learning about anything and learning about anybody and what matters to them. So curiosity is at the center of this. Next slide, please, Bob. And then with curiosity and deep listening comes the learning about what it is that we are trying to gain from our discussion or conversation with another person. Next, please. And then alignment, as we learn about what is important to them and what's important to us, other areas that we can explore that we naturally align that we weren't aware of because we didn't ask the right questions or we weren't receptive to what was being said. We had to pause to listen to be able to understand what was important to them. Next slide, please. And if we're not aligned, is there a way that we can negotiate to get to a place that meets both needs? This could be from the perspective of a provider and a patient, and this could be between co-workers or leadership and management or leadership and staff. And then finally, if there isn't an area that's obviously ripe for negotiation, maybe we need to think outside the box and really think creatively and innovatively about something that neither party has thought through before. That's sort of evolving from the alignment opportunity or the negotiation opportunity. So next slide, please, Bob. This is very resonant with how Maureen started the presentation around leading with empathy and being humble and genuinely honest with ourselves about how much we know and how much we don't know, and knowing the limitations of our own kind of mental models for understanding problems or potential implicit biases that we bring to a conversation, and therefore pausing to be curious and leave ourselves open to learning new things. Next slide, please. And you can keep going. I have quite a bit of animation in this that we don't need. So, many of you would have seen this elephant, and, it really reinforces the point about where you stand, determines what you see and what you do not see, and reminds us all to stay curious at all times, because we really don't know what we don't know. Next, please. And Maureen, if you want to talk about the curiosity quotient.
Yeah, so I think I'm always teaching for people to think about these 3 things, these 3 skills. IQ, what are you learning? What are you reading? Just being on these calls, I learn something every single month. Reading from Paul Batalden and Len Berry on this call. So that part is, I think, more normally built in for us. The EQ, we'll talk more about that in a few minutes, but it's really understanding, like the walking in your shoes. What is it like to be on both sides of the clinical encounter? But today we want to talk more about CQ, and that is your curiosity quotient. And I think a lot of times we have to build this, because when we go through clinical education, we're kind of honed in to focus on the organ or the lab results or and I think right now we really need to learn about curiosity and how to build on that. I work on my curiosity all the time. I went to take my little dog to the vet, and as stressed as I was by her encounter with the vet, I came back learning something that was very powerful, because at the end of the visit, when my dog had to be hospitalized, every 12 hours, they sent a picture to my husband's and my cell phone of the dog with a little note under it that said she's eating. And I thought, wow, if they can do that at a vet hospital, why can't we do that to connect patients with families at home? Everywhere I go, I'm curious and learning about bringing ideas back. I would encourage you to think about this like every Sunday. Think about your week. What did you learn and how can you focus on your curiosity as a skill?
I love that story, Maureen. You know, it reminds me last year, one of my nieces was in hospital having surgery, and it was at a very renowned hospital in the US. And one of the things that they did that I really appreciated is that they asked the family members for our phone numbers and gave us a unique ID for the patient that we're most, you know, obviously we're there for. And they had a screen with the patient ID's number. And each time the patient moved from one place to the other, we could see it on the screen and we're notified on our phone. So moving from pre-op to op, moving from op ready to go to PACU, for example, and then when we're ready to receive our niece in one piece, we got text messages, we got phone calls. I mean, the attention to our emotional state being in the waiting room as a family was so powerful. And I thought, why can't we do this? Why can't all health systems do this? Because we're so well trained to do the right thing surgically from an anesthesia perspective, taking care of the human being, for sure, the physical human being. But for the emotional part, for the patient as well as the family members, we're not as well trained to do that. So I thought that was a great example and obviously one that is worth sharing with other health systems. Next slide, please, Bob. So the next one is learning, and you can keep moving through the animation. It's really about the focus of this is appreciative inquiry as a way to get to empathy. Next slide, please. And it's very much related to curiosity. The more curious we are about the person, the more we are able to lean into open-ended questions, which is essentially what appreciative inquiry guides us to do. And the more open-ended and importantly, pausing after an open-ended question to give the person a chance to respond or reflect or chew on, decide how much they're going to share in what level of detail. And we have to learn to stop talking and breathe and pause to give the other person a chance to fill in that gap with whatever they want to share with you. But so much learning comes through that gap in conversation. And it's often easier to do that in person than it is virtually. Somehow virtually we tend to want to fill the gap. So we have to train ourselves if we're doing telemedicine or maybe phone consultations, we have to be comfortable with the silence in order to hear what the other person may have to share with us. Next slide, please, Bob. And then this really comes, you can go through the animation. This really comes to the listening, the appreciative inquiry, not just hearing not hearing the words they're saying, but really stepping into their shoes and trying to get a feeling of the emotion behind what they're saying, which is why in-person consultations can be so meaningful. Watching the body language, even watching the way they walk into the consulting room, or how they adjust their body if they are in pain, or all those nuances sometimes we miss. And I think being able to see them, hear their words, observe them, and feel whatever they might be going through at a particular time might get us closer to alignment, negotiation, or as the fifth attribute would say, creativity. So next slide, please. And this one is about alignment. Oftentimes as clinicians, as Maureen noted, we're trained to take care of the human body. We have certain protocols we're following. Some of them are obviously very technical, clinical protocols that we cannot deviate from a safety perspective. But there are others that are just rules and norms and things that we've been doing, but aren't as fixed in stone. So are there areas where we could potentially diverge from whatever it is that our system has been doing for years and do something different to meet the patient's needs or the family's needs? Next slide, please. And I'll hand it back to Maureen for the next one.
And so some of you may have heard me tell this story, but the listening for leaders is critical. But listening for our staff, our colleagues, is just as important, just as is our family. I recently met a young housekeeper, environmental services worker, from a healthcare system. And he was telling me that he had been called to human resources and told that he was being fired. And he said, why? And she said, because you've been calling in sick too much. And she said, we just can't take your unreliability, and you're fired. Go clean out your locker. When he went downstairs to clean out his locker, he opened up the locker door and started pulling everything out. And he started to cry. And one of the other workers said to him, what's the matter? And he said, I've been fired. And she said, why? And he said, because I've been calling in sick too much. And so they fired me. And she said, what matters most? Why have you been calling in sick? And he said, I'm going through a very difficult divorce. And if I don't go to court to fight for my 5-year-old son, I'll lose custody of him. He means everything to me. He means everything. And so the other worker put up a poster, construction paper on the wall and said, why don't we staff by what matters to all of us? Why don't we ask each other and listen to what really is going on, not just in your workplace, but in your life, because we're all people. And they created a staffing model. They made a guarantee to the leaders that they wouldn't cost more money and they would reliably staff every unit, but that they needed to ask each other and listen to what was important. And it made a huge difference, so much so that that new staffing model began to spread across the entire hospital, because that moment of listening really changed everything. And next slide. Another way to kind of really think about listening is to think about a day in the life of, when we're doing rounds, to engage patients and families, and not only just allow them to stand on the outside, but to really ask what's going on with you. And asking and listening really provides, I think, a course of action that's so critical for us. You know, just even, I always call it seeing with your feet, but just walk beside a housekeeper or a nurse or a physician. And that walking will really show you where we've got barriers to listening, barriers, language barriers, because we don't understand. We're all talking in our own languages. I mean, medical and nursing and pharmacy and the like, but also looking at hierarchical barriers. And you see those when you actually start to walk a day in the life of. Back to you, Nana.
Yeah, yeah, and the inefficiencies that we create inadvertently. You know, one of the examples that comes to mind immediately with this is around data systems. I've worked in health systems where, you know, the nurses in particular have to do so much documentation to achieve some data requirement. And the people who made the requirement aren't actually thinking as carefully as to what it takes in the nurse's day or shift to pause for all that documentation. I mean, nurses in some systems spend more than half of their time doing documentation rather than at the bedside. And when you draw attention to that, to the people who are requiring all that data, and the people are in the same room, that's where you can negotiate and actually get to a place where, well, we think, do we actually need this measured every day, or is it every week, or do we need this at this numerator level or denominator level? But until you can get to see the person's day and all the interruptions, you know, going to pick up this instead of that, and all the time away from the bedside, it's hard for maybe managers or data analysts or whoever needs that information to really recognize how disruptive our best ideas crafted in a boardroom somewhere or in some, you know, information management room somewhere may be affecting patient care. So definitely, this resonates very deeply. All right, so next slide, please, Bob. And that is a nice segue to negotiation, because oftentimes once you've learned a little bit, once you've explored where there's alignment, maybe there's an opportunity to negotiate around something. So next slide, please. Yeah, and Chris Voss is very clear that negotiation is really not around winning. It's not a battle to be won. It's not, you don't focus on your position so much, but really try and work towards common outcomes. So next one would be, I think that one goes to Maureen,
And so
co-production.
And to Paul. So Paul's on the line. And Paul, you have made such an incredible difference in this idea of co-production, which to me is, it begins with listening. To me, it begins with really understanding what the needs and the assets of the community are so that we can design a healthcare system with people, a health and healthcare system. I was on a call yesterday with people and they were just asking, how do I begin co-production? And my first bit of advice was to listen. Paul, would you want to add about anything about your article and your thinking here? I don't see where Paul went, but well, this was all Paul's idea, thinking about co-production, that we can't design healthcare and then deliver it with our own point of view. We've got to listen. And when we've done this around the world, it totally changes the way that we design care. An example is really nice improvements in dialysis care, with patients taking care of themselves now, looking at mental health care from a completely different perspective. And I think it starts with sitting down with a particular population and really beginning by listening. Back to you, Nana. Next slide, Bob.
Thanks. And this is a great example of that. This is a midwife from northern Ghana who, at the time, she was probably a mid-level, maybe 10, 15 years of experience, had just been posted from a relatively urban area to a rural area. And she was ready to deliver babies, but there were very few women coming to deliver babies. Most of them chose to deliver at home. And she didn't understand why. She felt like her skills were being wasted. And, some people would have been quite happy to sit in the health center and just relax and wait for the people to come. But this particular midwife, Hajia Mary Issaka, went to the communities and asked them, tried to understand why they weren't coming for much needed healthcare for labor and delivery when the risk of dying at home was quite high. And she learned from them that when they came to the health center, they weren't being treated with respect and dignity. Number one, they also really wanted a particular drink in their culture, in that part of the country. There was a myth or a tradition or a practice where women, after giving birth, would drink a particular millet drink called zumkum. And they felt it was really important to help with expelling of the afterbirth. And so if the clinic didn't have zumkum, they didn't feel comfortable coming. In addition, they wanted hot water to bathe with rather than the cold water that the clinic had. Very little things. And she said, oh, that's solvable. We can do this. And there's nothing stopping me from providing you with zumkum on premises of the health center. And we can certainly warm up the water for you if you want to bathe with warm water rather than cold water after delivery. And she did that. She also addressed the disrespect that the families had complained about, did customer service training with her staff. And within a few weeks, she started seeing changes. And you can see this, she's passed away now, but she was able to revolutionize this. And the reason this story was so touching to us was that this was one of those best practices that in many ways could be an island of, mediocre practice. But what happens is that best practices that are highlighted can then be spread. So, giving Mary a chance to tell her story, her simple techniques of listening to communities and learning what they need, what it would take for them to come for healthcare, she was able to spread this knowledge around the country, and more people started thinking about patient-centered care and how we can redesign and co-produce with patients, not just deliver care or just wait in our facilities for them to come to us. Next slide, please. And then the last one is our own creativity. What can we do to be a bit more innovative in how we deliver care, or how we co-produce with patients, how we co-produce with staff, engage our staff better? Next slide, please.
And so, when we're thinking about creativity, sometimes I guess one of the most common questions I get asked is, I'm so stuck in the rules, I'm so thinking about the legal situation, the professional guidelines, all that kind of stuff, that I get stuck in the rules. And so at IHI, we developed the Breaking the Rules initiative. and came up with some radical redesign concepts. And I frequently recommend that you kind of take these radical redesign concepts and maybe, I'm so old, print it out and stick it on your computer or something. But when you feel like you're stuck, when you feel like you're beginning a creative process and you need a little bit of inspiration, if you pull out the breaking the rules list, many times it will give you an idea of how to think in a creative way. Creativity, I think, revolves around all of these things, learning and creativity and alignment and negotiation, but really begins with stepping outside of your circumstances and seeing what you can bring from other places. If you go to the next slide, Bob, one example here in the United States is we had huge disparities in hypertension control between Black population and the white population in many parts of the country. And when we really started listening to why the Black men particularly weren't going to the doctor, weren't maintaining their medical routines, it turns out it was a matter of trust. There was myth in parts of the United States that said that when these men went to their doctors and they were prescribed a hypertensive medication, that it caused impotence. And so that kind of spread through communities. And so people said, well, I'm not going to take this medication. It will change my life in a very bad way. They couldn't feel the good way, but they certainly could feel the bad way. So they stopped taking the medication. And when people started looking around to say, where is their trust? Where can we learn how to listen? It turns out that the barbers were the most effective people. So in communities across the country now, when a man goes in to get his hair cut, there's incredible trust and there's tempo. They're in there once a month. There's trust. There's a sense of teamwork. And so barbers will say, okay, hi, sit down. How are we doing? How's the family? How's your dog doing? And okay, if I take your blood pressure. And they'll take the blood pressure. And then in many cases now, the barber will sign a small card. And if the man takes this card to his clinician and gets the clinician to sign it and brings it back, the next haircut is free. And so it creates this whole sense of trust and tempo and connection by saying, then they're bringing the card in, so they're showing it to their clinician, and it creates this new sense of team. Really, what we're seeing, as Nana said, really new places for care because people listen in a different way. We're looking at banks, we're looking at bars, men coming to get their health care evaluated and dealt with in bars because it's a place where they feel like somebody is really listening to them. Nana, back to you. Next slide.
And this is our last slide, just to summarize the 5 components of the leadership listening arc. Starts with curiosity, opens up the door to learning, and hopefully alignment if we can. If we can't align, maybe we negotiate some kind of a compromise, looking at the possibilities of co-production, and then, of course, creativity, thinking outside the box and really thinking about outcomes that we're interested in, not necessarily our positions where we started from. So that's it. And I think Bob's going to take us into breakouts, right? Or questions or reflections first before breakouts? Or would you like?
No, listen, I think some breakout space is absolutely cool for guys. That was absolutely amazing. I'm sort of most overwhelmed I've ever been. The amount of the stories you took us through and the content. There's only 836 resources that have sort of gone up in the chat and things. Thank you so much, everybody. It's there's so much rich stuff, but there's one bit in the conversation, and Amanda and Charlie and James sort of got involved, this piece about how we create spaces, and Bridget too, and questions asked in a right way to open up some different thinking, to hold that curiosity. There's a challenge for us. Let's not try and do that as a group of 65 or so on this call for a minute. Let's go to quarter to the hour in some breakout groups. I've put you into groups of 6 or 7. For those of you who are here for the first time, there's lovely people like Rachel I'm seeing in the middle of my screen. You'll just get lobbed in with a whole bunch of people who you've never met before, and it's a rather beautiful thing. So let's really think about that space and how, I know you guys do it very well, but how do we create some space for some different views? Maureen, is there anything else specifically you want people to focus on the breakout, or really just some reflections from people? Any guiding words?
Yeah, just we have a few really quick questions. One is just listening at work. I would love for you to share some stories about, do you have a way to reliably listen at work? You know, is there a specific time or place or some method that you use to listen? And then, so that's kind of at an organizational level. Then at a personal level, I would just say that many times we talk about microaggressions, and everybody's looking for that kind of little bit of anger that comes through in body language. I want you to think about micro affirmations. Are there little ways when you're listening that you can tell someone that you are hearing them? Sometimes it's just silence. It's just being quiet, as Nana said earlier. Sometimes, though, it's gestures like eye contact. Put your phone away. Just look up into the person's eyes. That's an affirmation that I hear you. I'm listening to you. Your expressions like nodding. And oftentimes, I used to think that listening meant you were quiet, but sometimes micro affirmations mean that you're going, and oh yeah, I know, like you're affirming that you hear, that you agree or you don't agree. But those little micro affirmations, I think, mean a world to improving your listening skills. So one, I guess, think about work. Are there plays or ways, methods that you use to listen? And two, you might practice some micro affirmations in the breakouts.
Wonderful, Maureen. Fantastic. So listen, we will go to just after quarter to the hour, whichever hour. I can't say like quarter to 7, because for about 30 people on this call, that means absolutely nothing. I'm going to press go on the move to breakouts. Remember the usual thing, it takes about 10 seconds to get there. If it goes wrong, you get lost, your computer blows up, anything like that, rejoin the meeting. I will be here waiting for you, and as sometimes happens, we'll end up create our own little group. So I'm pressing the magic button. I'm on 2 devices. This has got every likelihood of going wrong, but let's see, and have fun, and we'll see you back just somewhere between quarter to and 10 to the hour. Hello. Poor Lucy's obviously got somebody's put some bug in Lucy's computer. Sorry, that she gets stuck with me on a fairly serial basis. But anyway, look, the 3 of us have. Lucy, can you hear? Does your mic work? Anything in on the chat? Sarah, hello. How are you? Can you hear us?
Yeah, I can hear. Is James on the call as well?
Well, yeah, I was going to say there's more than 3.
Oh, there you go.
I know, because I in another lifetime I know I've met James.
Yeah, well,
James has blown my myth that London is full of sunshine, and at the minute it's looking a bit dark and grey over your shoulder.
Lovely
James.
to see James as well.
Lovely to see you all.
Lucy, perfect.
Hello.
Have a go on. So, what did you make of that? And thanks for your lovely comments in the chat. What were your thoughts as Maureen and Nana were talking?
So you're asking me?
Yeah.
Yeah. Oh, I mean, absolutely. I think the thing is with a lot of this is a lot of it is, to me, is like, it's sort of stuff I would expect. It's not like the highbrow stuff. You know, it's not high level. It's not go to university stuff. It's not all your incredible skills as health practitioners. This sitting here in my seat is like, my God, why aren't we doing this? Because I see from the other side the difference it makes. And I see the difference it makes to patients, but also to staff. And I just, so quite often, I mean, it's the first time I've been in a room with you, Bob. So, I mean, the thing is, quite often I've joined these and I think this is
so obvious.
It's so obvious. I didn't want to, because that is the point. It is so obvious. And I mean, I keep on hearing, staff just haven't got the time. And, you know all the pressures and everything. You know all those pressures. But, it brings so much.
Can I reveal a secret to you?
Yeah.
I'm going to really put my paediatrician hat on here about thinking about, and I was out yesterday in North Kensington doing a clinic out in a GP practice, really wonderful. I was also, which was great fun, trying out some ambient AI to record and make sense of the conversation. So I really didn't have to worry about the computer in any shape or form.
Amazing.
In terms of the interactions, really special. And the secret I'm going to reveal is it's also blindingly obvious that this stuff makes a difference from the clinician's perspective as well, which makes it even more nuts. So it's not like this is just a patient perspective on things. This is totally, Len Berry's wonderful work, I watch it play out in front of me. Around a consultation yesterday with an absolutely amazing late 20s woman who was there with her 10-year-old. Said, I had my boy when I was 19 and massively struggling to get him to sleep. That was the key piece, and it was just absolutely getting in the way of her. She said, how am I ever going to get a job? Talking about her relationship with her partner. Very, really wide, complex sort of stuff. But right at the heart of the conversation was about listening, was about, me really playing back that, look, I don't think you're crazy. This stuff is super hard and, massively affecting. And so that's the thing that we've got to think through our leadership bit, that with, Lucy, you and I in our leadership was a time and again not talking about this stuff. The whole mantle about operational performance and widgets and all this sort of stuff. We've got to get back to talking about stuff. Sorry, James, come on in. Kathy, welcome.
Well, yes, hello, Kathy. I mean, there's an irony here because I'm aware of how short these breakouts are, and I'm going to try and say one thing, and I'm cutting into Bob to say it about listening, which is I'm quite loquacious, and I don't think I'm a good listener. But I'm trying to get better, and I'm doing a coaching program at the moment, and that is giving me all sorts of techniques, but also legitimacy, just to listen. And what I was prompted to say by what the two of you just said is that there is something really wonderful. We talk about the power of listening, but there's something really wonderful about the act of listening for the listener. And part of it is around, most of us here might find ourselves in situations where we seem very pressured, everyone's very pressed for time. We're all about, let's make decisions, let's get to action. And rightly or wrongly, we sort of feel that people are looking to us to respond. But if you go into a context where your job is just, it can be simply an exercise, where you just have to listen for 2 minutes. But I just think it might be useful if we think about not just the listenee, the person being listened to, but the listener as well. And the leadership roles, Lucy, Bob, lots of people in these rooms have unbelievably hard, exhausting leading roles, and I wonder if they can be made a little bit easier by legitimizing listening.
Yeah. And just making a link, James, there's a really there's too much in the chat. I say never too much. Rich Frankel's put a super interesting bit, and Kathy, I'd love to bring you in on this, and hopefully Lucy's got some microphone. Rich Frankel's written, I'm loving this conversation. I'm curious to know if there's any work available on listening and stress. My own experience is that one of the first things to be sacrificed when folks are really stressed is deep listening. How can we learn to still the hurry up voice in our heads that limits our ability to listen? As ever, Rich is like a poet, isn't he, the way he sort of writes. James, I'm going to leave you with one final little trick. So the joy of being an improver who understands PDSA cycles things is I use my clinical consultations, despite being in year 26 of them, to continue to do PDSAs. One of the ones that I absolutely love doing is physical body language things that slow things down. So what I mean by that is on a ward round, for example, absolutely with their permission and making sure that there's not profuse diarrhea or some highly infectious thing, is sitting down on the end of a child's bed, giving the verbal message, the visual message of I've got all the time in the world. And just one thing to reflect on, when you ask people who you haven't seen for a while, how are you? I'm willing to bet whatever money you want to take off me, because you won't take it off me, that at least 9 out of 10 people, they might say I'm well, they'll say busy. What does that mean? What does it even mean? Kathy, come on in. What does busy mean, hey?
Yeah, busy is overrated for sure. So I've recently just changed jobs. I was in private practice, in a busy private practice, which is like capital B, and just awful. And I've moved to an academic medical center. So now I'm training medical students and residents. I'm also seeing my own patients, but as a generalist, I'm working in a gastroenterology clinic, seeing the kids with chronic constipation and irritable bowel and like the things that really need a quality improvement person, or they really need someone who knows how to talk about sleep and not so much how to talk about their gut, right? So I realized as I was listening to the 4 types of deep listening, the downloading, and then I'll have to go back and look at them again, because the thought that was going through my head is I had a mom in whose 7-year-old was chronically constipated, and she said, actually, he's never, ever been potty trained, which was not true. And she just needed some reframing in a few like key ways. He also has pretty bad ADHD. And so that his body self-awareness, like I think that was maybe the key, like the one thing that I could say to her in that appointment that's going to kind of unlock the motivation to make this a thing that they're going to do together, as opposed to you're not potty trained yet, I'm scolding you, he's getting embarrassed, all that sort of thing. It was nice to be able, first of all, it was nice to be able to have an hour to do that, because I've never had that before. And it was also nice to know that I didn't need to do the medicine with her, because she knew all that and she was doing exactly what she needed to do. I really just needed to listen to her so that she could listen to him. And it was a great interaction.
We should set up a pediatric clinic together, Kathy. I absolutely love that. Listen, we've got a couple more minutes before the gang come back. Lucy, do you want to? Can we? Yes, we can hear from you. Hello.
Yeah. Sorry. I can. Yeah, you can hear me. Yeah, the thing I was thinking when we're talking about, why is it so hard to just do the obvious listen? Is it because both as doctors and as managers, we're so trained to want to fix all the time, and actually that you're kind of wanting to jump in, your instinct is to jump in with a solution, as opposed to the calm and the peace and the healing in itself, that is being alongside somebody and listening to them. And I think the most meaningful interaction I can remember in my family with any doctor was, were the ones where they couldn't solve the presenting problem at all, but they really, really listened and were just kind of somehow held the space and were calm and helped see a way forward without necessarily fixing.
And we could measure this. I was at a national improvement meeting today, and the big intervention I made was getting people with some others actually helpfully, and a couple of really, non-clinical guys who really, much like you've just done, Lucy, brought in this piece about people's experience of care. And actually the question, was I listened to? Did I feel listened to?
Mm-hmm.
Is a very, very measurable piece around it. And goodness me, that's absolutely something that we could, and indeed, right, the politicians in this country are all over trying to, the connectivity between the NHS and politics is so close. But of course, ultimately, if people don't feel listened to, they don't vote for people. So it's perhaps one for us to explore in that sort of level. Listen, you just finish off for 30 seconds. I'm going to bring everybody back, but beware the arrival of a chattering lot of 60-odd people. But let me just quickly do that.
One of the greatest things that I have is when I leave my cancer unit, which are treating me, the staff saying, "Hope you're going to get a Greg's hot sausage roll on the way home, Sarah." And that is them knowing that is something that helps me get through. And equally, when I see them and I know they've been on holiday or I've not seen them, "How are you? What was the trip to Greece like?" It's that. It's
the relation back
you
to
want to be.
the relational side.
It is.
Right. Well, welcome back. This is I say exactly, Lisa, exactly right.
Landed safe and sound.
I'm happy that you're safe. Listen, I always worry. I know, like, from an ethical perspective, I should count you all out and count you all in, like some sort of year 4 teacher going on the trip round the park. But I trust you can all look after yourself. I'm sorry, it's always a bit bumpy. That was short, but I have no doubt sweet. Maureen and Nana, I've totally lost off my screen. No, I haven't. I've completely lost them off my screen, but I hope they're back with us. It would be great.
I'm here.
You're here. Fantastic. I feel a sense of responsibility, Maureen. Listen, what would be great? We've only got 10 more minutes. If you've got, we'll hear from 2 or 3 groups. If you've got particular things that you picked up, reflected on, learned, please do put them in the chat. It does help us to collect them. We'll have a bit of a read. But let's hear from 3 or 4 people, and then we'll get Maureen and Nana can sort of weave in some conversation. Come on, I've never met shyness on this group. Who's game to just tell us a little bit about what was going on things? Otherwise, Sarah, you might have to explain your Greg's piece on here. Are you happy to start on that, Sarah? Come and say hello, because it was a beautiful, beautiful story that you did.
Okay. So just very quickly to say, I think one of the key things from our group, which really resonated, was giving legitimacy to listening. That's really resonant. How can we give legitimacy to listening when, it is such, dare I say, and the thing that you would expect to be happening, but which seems to be the trickiest. So giving legitimacy. So it was basically going back to the mango moment thing. I suddenly popped into my head was that when I leave the cancer unit that are treating me, staff always say to me, "Hope you're going to pick up a Greg's hot sausage roll on the way home." And that says everything about care. It says everything. And in the same way, and I leave with that warmth. Oh my God, they've remembered. I get a Greg's hot sausage roll. It's helping me, and also in the same way, it's me showing that kindness of care to staff as well. They've been on holiday, not seen them for a while. "Oh, how have you been? I've missed you. How was your holiday?" Little things.
Brilliant, Sarah, thanks. And of course it links, and I saw Rich Frankel, who was on the call earlier, and Rich's wonderful session before Christmas, really. Rich, there you are. You taught us so much about encouraging particularly those of us who work clinically to open ourselves up a bit, actually to let Sarah know where we are going on holiday, to have that conversation and build those. Rich, come on in, and then maybe you can tell us a bit about what your group was up to.
Sure. Thanks so much. This has been a wonderful conversation, a wonderful presentation. So in our group, we talked a little bit about the difference between deep listening and shyness. You know, there are some people who are introverted by nature, and so listening is kind of a second nature to people who are a bit introverted. And then we talked a little bit about the question of listening under stress, and the fact that this is a skill that can be taught, but it does take training, and that deep listening is probably the first thing to go when people are feeling really, really stressed. So we talked a little bit about stress and listening. I wonder if there are other members of our group who'd like to comment. It was a great conversation.
Thanks, Rich. Anyone else like to come in? Just come off mute or give us a wave or stick a hand up. Anyone else? Nikki, it's all. I always get very excited to have you on the call all the way from New Zealand and things. Do you want to come in and say hello and maybe tell us what your group are up to? We're up to.
I am actually going to. We had a lovely group, and we spent lots of time listening to each other, and being slightly off topic, in the listening. But that's what it's all about. I'm going to pass over actually to Amanda or Rachel or Romilly. I think, shared the spotlight a bit there.
I wanted to say just a shout out to Rachel and Romilly, medical students who are joining this group. And I was just so delighted to have two of them, because I think this is about culture change, and it takes such a long time, and it's really hard when you're doing this to stay in it and see the change. And I think to have people being part of this conversation right at the beginning of their career in healthcare is a beautiful, wonderful thing. So I hope everybody welcomes Romilly and Rachel, and you stick with this conversation and with this movement of practice that I think lots of us here think really is the key to changing so much in healthcare, and making something that can be quite painful, not just because being ill and needing healthcare is painful, but the actual healthcare can be a very difficult, violent, abrasive experience, and I really believe it doesn't need to be. So it's lovely to have you involved. But you should say something.
Beautifully done, Nikki and Amanda. I don't know, Romilly or Rachel, do you want to, if you'd like to, and you Romilly, come and say hello, because we hear from you lots, and it's just always wonderful. And Maureen, I might pass then the baton to you, because we're pretty passionate about exactly what Amanda's talked about, hasn't it? And some interesting. But Romilly, come on in and say hello.
Hi. No, I would very much echo that, and thank you. I've been coming for about a year now, and I have not missed a session. It's been like the highlight of my month. It feels very I would describe it as energizing. Every month it's really nice, kind of getting away from the sort of I guess technical, very academic medicine that kind of gets drilled into you, and being able to actually have these kind of discussions and get a new perspective on things. So interesting and so helpful, and it is something I always really look forward to. So thank you for having me.
Fantastic. And Rachel here for your very first time, but brilliant, absolutely brilliant to have you here as well. Maureen, do you want to talk a little bit about, I guess, what you've been hearing, and just as by way of wrap up, a reminder as well, and Lucy, apologies for not putting it in the chat. Lucy's put a new Blue Sky account and has been nudging me to get myself sorted out. I've been a bit slow on social media recently, but there's a at Kindness Healthcare .bsky.social in the chat. If you're on Blue Sky, please do join it. If you're not on Blue Sky, I think we're all being nudged in that way. But Maureen, you, I, and a good number of other people on this call who've taught are pretty convinced that influencing our education systems. We've got people like Sanjeev on the call who runs a medical school. So there's loads of influence around here. But Maureen, do you want to just say a little bit about that? And then let's maybe pass to Nana for some final reflections too. And then we will wrap things up.
Sure. Thank you. Thank you all. I guess one of the things I was thinking about is I'm hopeful that Bob knows that every month I'm saying, how can we change the medical and nursing education processes to build this in as a part of our normal ways to care? And so I care very passionately about that. The other thing I'm thinking as we're talking, and we had a wonderful breakout group, is I wonder if some of us could get together and write or share at a forum or something, some very practical ways to teach what we're talking about. You know, I think as we've been talking, Richard, you have comments about stress and how that impacts your ability to listen is so powerful in today's stressful work environment. But maybe we can help people to see some practical ways. I have a sister who's has no joy in any of her interactions with the healthcare system. But she called me the other day and she was so happy. She said, I had the most amazing visit with my primary care doctor. And it was a new physician that she hadn't met before. And I said, tell me. And she went in and she said, when she sat down, he pulled his chair up too close to her and he said, let me introduce myself. My name is Dr. Roy. I've been doing this now for about 14 years. I went to medical school here. I do this every single day. A little bit about himself. And then he said, okay, that's me. Tell me about you. She said the whole thing only took about 3 minutes, but she came away with trust, with a sense of that she could talk and he was going to listen. And it totally changed her perspective. So I'm thinking if we can share some very practical tools and ways, micro affirmations, small ways to introduce yourself, ways to pause and listen quietly. Some of those things might be very helpful in helping us to change the culture of today's healthcare, but also to influence the education of our future. And Nana, just before I turn it over to you to close, I just wanted to say next month we've got an amazing presentation by Steve Swenson from Mayo Clinic. And don't miss it. He's been writing a lot about kindness. He's an ideal, excellent radiologist with a kind spirit and soul that he's incredible. So Nana, over to you to close.
Thanks, Maureen. In our small group, I came across other people who are also chatty. I didn't say at the beginning, but I am a chatty person. I've been very chatty since I was born. And so for me, this has actually been part of my intentional learning as a professional to become a better listener. And I found I found two people who actually identified themselves as chatty. And I like the fact that you brought up the introverted nature. I think it was Rich who brought that up, that for introverts who are used to listening, this may not seems so challenging. I think for people who are extroverted and chatty, I think this is a skill. And I'm so glad to see people early in their career, like the medical students, and those of us who've been doing this for 20, 40, 50 years and are still learning. So this gives me hope that we can all get better. And we all have tips and tricks for how we can be better listeners. And I think the idea of writing something together is a good one.
Wonderful. Listen, with beautiful elegance, the two of you have led us through the most amazing hour. Thank you so much. You've hit 7 o'clock UK time and on the hour across the world in beautiful time. Thank you. That was absolutely wonderful. I had a lovely catch up with our friends at Kaleidoscope. We've got a little bit behind on getting the previous videos up, but we're going to do a big whir away to get that caught up. As Maureen mentioned, we've got Steve in February, and we've got the wonderful Amanda and her fabulous contribution with Friends in March, if I've got my dates right. And we've got a great plan for the months ahead. But listen, some scheming going on in the chat, and I think James will be following up on a few of those bits and pieces. Take care, everybody. Have wonderful evenings, rest of days, mornings, or wherever it might be. We will catch you on the 20th of Feb, if not before. Thanks, everybody.